Hi, welcome to the lecture on striving for equality in health in people with developmental disabilities. This is just an overview of the content that you're going to see today. So let's talk about what we mean by health inequalities. Well, it's differences with the general population in terms of enjoying good health and access to services. We've mentioned before that people with developmental disabilities are experiencing increases in their life expectancy, but they're still not living as long as other people. They have increased rates of morbidity, that is, particular conditions that impact on their health and well-being. These include hearing and vision impairment. Many have severe forms of epilepsy. Sometimes it's quite difficult to control. Many people experience psychiatric disorder. People with developmental disabilities are at the same risk, if not more, really, than the general population of experiencing these sorts of problems. They can also have gastrointestinal problems such as dysphagia, which is eating and swallowing problems, H. pylori, which is bacterial infection causing gastroesophageal problems, and they can experience things like reflux quite frequently. Let's just take an example of Down syndrome. Okay, so we know people with Down syndrome have the comorbidity of intellectual disability. That is a problem that coexists with their underlying disability of Down syndrome. Other concerns or comorbid conditions include having congenital heart problems. They may have gastrointestinal problems. They can be prone to respiratory infections, including acute and chronic otitis media. That's middle ear problems, which can cause quite chronic earaches, particularly for young children. And many experience sleep apnea. Many have vision problems and hearing problems. Hypothyroidism can also be a problem for people with Down syndrome. They have high rates of diabetes and alopecia, which is literally hair falling out, which can cause them to have very thin hair. Their skin can be very dry, which exposes them to a range of skin diseases. They also, because of their low muscle tone, can experience musculoskeletal problems, which can cause problems with their hips, knees and feet. Many have atlantoaxial instability, which is a problem with the cervical part of their spine, which can be quite dangerous in some. People with Down syndrome can also experience anxiety, depression, obsessive compulsive disorder. And many have high rates of Alzheimer's disease, which appears to be related to the extra chromosome, chromosome 21. And they tend to be diagnosed with Alzheimer's disease earlier. And you would have heard about this in the previous week. Let's look at another example of cerebral palsy. People with CP have musculoskeletal issues because of their physical impairment. This can result in muscle weakness. They can experience stiffness and slowness in movement, and they can experience muscle pain, and particularly if they're ambulatory, balance problems. They can also demonstrate involuntary muscle movements, looking as though they're lashing out when they're not intending to. And these sorts of problems can cause strains and lead to wear and tear in their joints, cause them to fall and have fractures, and they're at increased risk of osteoporosis. If they don't have appropriate support, such as in seating and positioning, they can also develop deformities known as contractures, caused by contractures. In addition to their health or their comorbidities, they are at risk because of their negative determinants of health. 80% of people with intellectual disability in the world live in developing countries. But even those who are in developed countries, such as Australia, tend to be socioeconomically poor, in that they may be on a disability pension and not have a lot of free money for other things. They also have limited social networks. They may have few friends and be reliant on mostly family and paid support people, such as support workers, to be the main people with whom they interact. Few people gain meaningful paid employment. They may have access to various social enterprise work through day services, but they tend to be unemployed otherwise. As a result of the communication issues that people, particularly those with moderate to severe to profound disabilities, experience, they really struggle to express pain and discomfort. And they also have difficulty in expressing anxiety or depression. So instead of being able to talk about how they feel, they may demonstrate these types of problems through what we call behavioural indicators. And that means that those people who know the individual well will notice changes in their behaviours or overdoing things that they didn't do before. So, for example, they may do more of self-abusive behaviours such as hitting themselves because they're in pain, or they may become disinterested in activities that they used to really enjoy, and that could be an indication of depression or anxiety. So people who know them need to be looking out for these types of indications. So what do we do to try and rebalance that the problem of health inequalities? Well, we need to address the problem that they experience in accessing services, and this is about enabling our mainstream services, that is, services that you and I are able to access fairly readily, like going to a local GP or getting a physio appointment when you need it. And we do this through education, such as the education you're involved in now, and also through less formal education, such as taking the opportunity to share what we know about disability, whether it's on a professional basis or less formally. Collaboration with disability services and professionals with mainstream services so that they can share their knowledge and understanding about disability. We look to those mainstream services to make reasonable adjustments, that is, to do things that will make their service more accessible to a person with developmental disability. And that may be something as simple as taking the time to learn how the person communicates and to try and understand their message, or to understand that they may struggle to let you know where it hurts. And so a reasonable adjustment may include something like listening to what the person who came with the individual, such as a family member, say about what they know may be happening for the individual. They need access to support such as health prevention and promotion. Often people with developmental disabilities don't get the opportunity to engage in things like healthy living programs that are offered through community. Also having multidisciplinary teams input into their overall care and support so that individuals on those teams can contribute in the area of their expertise so that the person gets a holistic support to so that they can strive towards health and well-being. And the other thing is to be engaged in self-determination and to be supported to make decisions. Self-determination simply means having a say in what happens to you, so that when we go to the doctor, we are part of the decision-making process when, for example, the GP suggests a particular method of treatment. We will be able to say what we prefer or what may fit with our lifestyle. Even people with quite significant disabilities can be supported in that people who know them well can come to a consensus around what they feel is in the best interest of the person, but that the person would choose if they were able to express their choices. Now it's time to return to the LMS to view the video clips and to explore some of these concepts more fully.